Okay, this is the first of two atrial dysrhythmia slides or videos that we're going to talk about. The first one is what's called a premature atrial contraction. One thing you have to know about a premature atrial contraction is a PAC is just an anomaly. It is not the underlying rhythm. So you would treat it like the ST segment abnormalities. You would never tell me someone has ST segment depression and that would be what was called their underlying rhythm, because that makes no sense. It's the same kind of concept with premature atrial contractions. These are anomalies or blips on the screen that we need to address, but in order to tell me the full picture coming from the EKG interpretation, you have to tell me what the underlying rhythm is. Now, when you're talking about premature atrial contractions, the two things that make an anomaly or a blip on the screen of premature atrial contractions, number one, it's early. Always has to be early. Number two, it has to have a P wave, a discernible P wave. Although that P wave may be a little bit difficult to see, that P wave must be present and it must be upright. So those two things have to occur. The beat has to be early and the P wave has to be upright. Okay? So when you're talking about rhythms that include PAC, it can be any kind of underlying rhythm. Normal sinus, sinus brachia, sinus tachycardia, whatever. The faster the heart rate is, though, the more difficult it is to see if the beats are early, because as the EKG squeezes together, typically things start to look a little more regular. But these are yet another reason why you have to start from the left side and work all the way over to the right side in order to get a good interpretation. So let's look at this particular slide. So again, we're going to look at regularity first. If I put my calipers here, I go from here to here and here to here. So far, very regular. I go from here to here. That's my first sign that there's something wrong. But I noticed that that beat came significantly early. So I'm going to take my pencil and very lightly circle it, trying not to disturb any of the complexes. But I want to make sure that I don't forget to address this. When I go from here to here, because I'm still trying to measure regularity, it's not regular, but it goes right back to measure the first part right here. So that's regular again. Then I notice that, oh, there's another problem. That beat is also early. So again, I'm going to circle that lightly. I try to go from here to here. Nope, not regular. But from here to here, it goes back to regular. So my underlying rhythm on this strip is regular. I just have two complexes here and here that kind of throw it off for a second. And then it goes right back to regular. So I'm very comfortable saying my underlying rhythm is regular. Well, because it's regular, I can calculate a heart rate. So I'm going to count the big boxes here, and there's 4 big boxes, 300 divided by 4, that's high 60s. So calculate it, you can do that with your calculator. But it's well within what we call normal sinus rhythm, okay? The other thing I'm going to do is go to my P wave. I see a P wave here, here. It's upright, it's not peaked, looks very normal. Here, here. And then when I get to this early beat, because I know it's early, I know there's a problem, I've circled it, I notice there's a P wave and it's clearly upright. So I've got an early beat that has a P wave that's upright. So in my head I'm thinking, I'm probably dealing with a premature atrial contraction. I go back to here, which this beat is part of the underlying rhythm. P wave looks just like these P waves. I go to this, same thing. I go here. Now here's where it might get a little confusing for you. There is a P wave hump here. It's a little bit like a McDonald's hump, very difficult to see, but there is a second hump, if you will, and it's cleared and upright. So that also is an early beat and has an upright P wave. Then when I look at these, which are part of the underlying rhythm, they match these P waves. So my underlying P wave is normal and it's upright. My two complexes that are early here and here also have a P wave and it's also upright. I then want to look at my PR interval. Measure just like you've measured before, go all the way across. So my underlying rhythm has a PR interval that's about 4 boxes, maybe 5, so 0.16 to 0.20. My QRSs, I also have some ST segment elevation, which I can clearly see here. So my QRS is about 2 small boxes, maybe 2.5, so 0.08 to 0.12 or 0.10, very, very normal. I do want to make a note that I have about a 2 millimeter, might want to call that a 3 millimeter ST segment elevation. Then I look at my T wave, very normal, not peaked, and it's upright. So far, I'm very comfortable saying the underlying rhythm for this strip is normal sinus rhythm with ST segment elevation. That's it so far. But I also have to address, this is a complex, a complex, a complex. So 1, 2, 3, 4. What happened at the 5th complex, 6, 7, 8, and what happened at the 8th complex. So I look at the first early complex. Again, it's early. I look at my P wave. It's upright. My QRS is very narrow, so I know the complex started above the ventricle. I'm going to call this a premature atrial contraction. Remember, the two things you have to have is an early beat, that's where the premature comes from, and atrial, that's telling me that the P wave is upright. So that's a premature atrial contraction, or PAC, at the 5th and then the 8th complex. So the overall interpretation of this 6-second strip is normal sinus rhythm with an elevated ST segment and 2 PACs. You can say 2 PACs at the 5th and 8th complex if that makes you feel like it's more complete, that's fine. But you must tell me that there's 2 PACs. To just say normal sinus rhythm with elevated ST segment and PACs, no, you have to tell me that there's 2. I need to know that you've recognized there's 2 extra anomalies. And now the treatment. The treatment usually comes from treating the underlying rhythm. In this case, it's normal sinus rhythm. Unless my patient was symptomatic, we wouldn't be treating this. About the only time that we would treat it if the PACs were very, very common and that doubled the heart rate and made the heart rate go too high, then we would look at what we call electrophysiological studies. They may temporarily slow the heart rate down by a beta blocker, a calcium channel blocker, or some other means. But typically, PACs, unless they mess with the heart rate, really don't denote separate treatments. Then we're looking at a wandering atrial pacemaker. Very unusual rhythm, dysrhythmia. You don't see it very often. With a wandering atrial pacemaker, generally the rhythm is irregular. So that's one of the first clues there's something wrong. But the name says it all. Wandering atrial pacemaker. The pacemaker is moving. So instead of it being the SA node, it might start there, but it might move to the internodal fiber trackways. It might move to the junctional tissue, might move back up to the SA node, but it's moving. That's a problem. It's a problem because, as we discussed in class, depending on where that origination occurs, will usually dictate the underlying heart rate, and it can be detrimental. It can be very, very slow. Also, we really don't want the pacemaker to occur anywhere outside the SA node. So with a patient with a consistent problem with the pacemaker origination, no matter what the rhythm occurs, you're usually talking about a pacemaker insertion at one point. It may not be an emergent type of scenario, but that's generally going to be the ultimate treatment for patients. So again, that's basically the treatment with most WAPs or wandering atrial pacemakers. But again, because the pacemaker is originating from multiple sites, generally the rhythm is irregular, but it's really only slightly irregular in most cases. Okay? But if you march this across, you'll see that it gets off by about 2 to 3 boxes here and there. Okay? But the thing to call it a wandering atrial pacemaker is you have to have at least 2. Most clinicians are not comfortable diagnosing this unless there's at least 3 different, distinctly different P waves. So that's really what denotes it as a wandering atrial pacemaker, is a heart rate below 100, and you have at least 2, in most cases they want 3 distinctly different P waves. Okay? So let's look at this particular strip. Again, start at the left and go all the way over. This is the classic reason why you go all the way to the end when you're looking at every single aspect of an EKG. So when I check regularity, I notice it probably goes off a little bit here and there. So I'm comfortable saying it's slightly irregular, but nothing worrisome. I look at my P waves, upright, 1 for QRS, fine. Looks just like the other one. Oh, that's a little dampened or depressed. Dampened is probably the best word to use here. You can slightly see an upright blip, but it's significantly different here. But you can tell that that's not a straight line. It's a little bit upright. Okay, but then I go here, and that's definitely different. Now you're seeing a definite inversion, and in here, and the rest of it is absolutely inverted. So I've got 3 distinctly different, actually I've got probably 4 distinctly different looking P waves in this 1 6-second strip. So it's clearly a wandering atrial pacemaker. Again, I'm going to look at my PR interval. Can I measure it? Sure, but it may vary as well, but it's usually within the normal limits. You know how to measure that by now. QRSs, it doesn't matter where the impulse arises, as long as the impulse arises above the ventricles, anywhere in the atria, then the QRS is going to look the same. Because the ventricles do not care where they get their impulse, they just want it to originate above them. If the impulse doesn't originate above them, the ventricles can originate their own, but the strip looks really, really ugly, and the ventricles get really, really pissy. They can get in a really bad mood and say, screw it, I'm not going to beat anymore. That's the problem. But here, while it's moving around the atria, we're still getting an impulse to our QRS. So the QRS complexes are going to look the same across. That's very classic with a wandering atrial pacemaker, okay? So treatment, again, most likely, if it's an emergent type of treatment, it's most likely driven off the heart rate. If the heart rate's too low, we're going to treat that like a bradycardic scenario with symptoms or not symptoms. In that case, do we give them atropine to speed it up? On an emergent basis, we might, but that might exacerbate the problem with the origination moving. Most likely, if their heart rate falls off, we're probably looking at an emergent pacemaker insertion. But a pacemaker insertion is generally the ultimate treatment modality for a patient in a wandering atrial pacemaker rhythm. Now, with a multifocal atrial tach, this is the exact same thing as a wandering atrial pacemaker, but the heart rate is above 100. Very unusual to see. This is typically the type of patient you're going to see a multifocal atrial tach, and that's where you have COPD with your patient, specifically if that COPD is exacerbating, because a diseased set of lungs will usually put a tremendous strain on a heart, and then that can cause a patient who's susceptible to their pacemaker moving for that wandering atrial pacemaker to jack itself up above 100. Typically, this is going to be an emergent type of treatment. We're going to usually put a pacemaker in, but this is going to denote some emergent type of treatment, the COPD relation. So that's about the only time you see that. Now, the last thing we're going to talk about is SVT, or supraventricular tachycardia. Sometimes it's called atrial tachycardia. Sometimes you will also see a P in front of the SVT. So it can be PSVT or PAT. Atrial tach and supraventricular tachycardia are synonymous terms. The P in front of it stands for paroxysmal. Paroxysmal means it comes and goes. So you'll see runs of it and then runs of the normal rhythm, runs of it. So if you see PAT or PSVT, that's what you're talking about. But SVT, or supraventricular tachycardia, that's probably the most common term you'll hear in this region, probably in this country. You go out to more of the European type of scenarios, you're probably likely to see atrial tachycardia used. But again, it's a synonymous term. What's occurring here is that the rate is well above 150. So when we talked about sinus tachycardia and the treatment modality for that being a little more on the laid back side, because it doesn't necessarily mean the heart is stressed, all bets are off with SVT. With SVT, your heart rate is well above 150, usually closer to 200s. Complexes start to disappear. Like in this one, you can see the P wave, but the faster it gets, actually this is more of an sinus tachycardia. But as we get to faster heart rates, then you'll see this P wave start to march up into the T wave and disappear, okay? I thought I had one on there, but I don't, to give you a better look at an SVT. But just note, the faster the heart rate, the more that P wave marches itself up into the T wave. So you would measure this just like you did with the sinus tachycardia. The only difference between that and sinus tachycardia is this particular rate is well above 150. Treatment modalities, typically this is going to be treated. Again, you can use the beta blockers or you can use the calcium channel blockers. We can also use things such as adenosine. They can do carotid massages. We can stimulate the parasympathetic nervous system, usually rectal stimulation. They can do that as well. So Valsalva maneuvers. Typically, though, we're looking at some kind of pharmacological agent to treat this because the rate is so fast. okay? So be very, very careful with this. A lot of times you'll see this be so fast that the only thing you see are the QRSs and then a T wave, QRS and a T wave, and you don't see a P wave. That's very classic for a very fast heart rate. If it gets fast enough, the T wave will then walk itself up into the QRS, and all you'll see is a bunch of QRSs, and that's it. That's a very, very fast heart rate, okay? So that's the SVT. And that's the last thing we're going to talk about with this particular slideshow.